So who do we have today? We've got, looks like we've got Brian, Craig, and Runia. Hopefully I pronounced that correctly.
And of course, Macy is our student from the hub who is going to be helping us today. We could start off with our own introductions, Mitch, and then ask our guests.
Absolutely. So you go first, David.
Hi, I'm engineer and certified information systems security professional out in California. I've been researching medical device cybersecurity for a number of years now. I actually have some clinical background working in intensive care units and respiratory therapy. And we're working together, Mitch and I, on this IEEE standard that you may hear about more in the future.
Absolutely. And hi, I'm Mitch Parker. I'm the Information Security Officer for Indiana University Health, based out in Indianapolis, Indiana, and have been working on securing clinical devices from a different angle for approximately 13 years. My area of focus is in making everything play nice and securely on large enterprise networks, especially when you've got massive downtown hospitals that depend on good security. So who else do we have? Let's go around. Macy, do you want to go next?
Sure. Hi, my name is Macy. I'm Lebanese, and I'm a grad student at Columbia studying industrial engineering, and I'm a student assistant at the Northeast Big Data Hub.
Thanks, Macy. This is Craig Hypes. I am a principal engineer with a company called Order. Basically, my focus over past 15 plus years has been in the identification of devices that connect to networks and providing secure access controls and segmentation for those devices.
Welcome.
Thank you. I should also note that I'm also working with the IEEE group on the trust and identity working subgroup.
Brian, Runia, would you like to self-introduce?
Sure. My name is Brian Rumis. I'm currently a data scientist at a biotech company, and I'm just curious to find out more about what you guys are doing and what type of challenges you guys are currently facing. Day to day, I work mostly with Python and pandas and doing analyses there and trying to implement like machine learning algorithms. So not inherently, directly related to what the topic is here, I guess, but I'm here to learn mostly.
Welcome.
Hi, I'm Runia, and I am a student at Biomedical Engineering Department, and I'm a doctoral candidate. And I want, almost same as Brian, I'm not in the field, but I'm interested to learn more about the cybersecurity and how it works, data science, and everything else.
Well, looks like we run the range from a couple of people who work in the industry to people who are just getting started. Chris, I see there's a new name that also got added.
Yeah, I'm from IEEE, the project manager, but I'm also interested in the context cybersecurity and hospitals in regards to the software applications they're using.
Great.
Shall I go ahead and share screen?
Absolutely. Thank you so much.
I hope you're able to see.
Yes, can you hit swap displays?
Oops.
Welcome to the world of Mac.
Where's swap displays?
Okay, it's upper left of your screen. Right under the red bar.
Okay, now I lost it entirely. There. Screen is paused. Well, I may have to do what is that going to work?
Just need to make it a little bit bigger. I think our slides are, the font's big enough to where we can actually work with this.
How's that?
Screen hasn't changed.
Starting over. I think I'm going to kill my second monitor, and that may simplify things. How are we now?
Much better.
Second monitor has advantages sometimes. Anyway, we were tasked with talking about both software and hardware supply chain security and mitigating those risks. So we're just going to give a little introduction. The reason we're thinking about this is there are significant threats that are being identified, and they do need to be mitigated. But there are some things that need to be clarified about the processes and technologies that are involved. We've got about 10 minutes for this little introduction, and then we're going to try to break it up and kind of brainstorm with you the gaps. You can ask questions or make suggestions, then brainstorm a bit about mitigation. And then we're tasked to maybe develop some recommendations that we can bring back and report to the general group after our session. So I found this slide from the National Institute of Science and Technology, and they have there's a citation at the bottom, and I can put the these slides in the chat box in a minute. But they point out that as you get all of the components that contribute to building a device, you often have different suppliers involved. And every step along the way is an opportunity for an attacker to intervene and try to either install malware or somehow pervert the hardware and create a cybersecurity problem that would only show up later when it finally gets to the customer. The NIST goes on to talk about, if you look in the upper left, the manufacturers, what they're doing are producing the devices, which then the original equipment manufacturer or reseller is combining into things. And then it's the responsibility of whoever the customer is. Usually in our case, we're talking about healthcare delivery organizations, where they have to test this equipment and then maintain it. You may have heard recently in the news about the so-called SolarWinds sunburst attack. This is a pretty decent simplified diagram of what happened there. If you can see my cursor, SolarWinds built some code for an application to monitor networks. And as they built this, an attacker was able to get into their system and install malware, which was then onto the server when this software was being updated at thousands of customers. So the malware went along with the software and ended up on the customer's machines, included Fortune 500 companies, probably included some hospitals along the way. And a unique feature, or maybe not so unique to this malware, is that there was a back channel where the attacker created their own server out on the internet, which was able to communicate with the customer's system due to this malware.
And I can add on a couple things, David, from our point of view. We've had several vendors so far that have admitted having the vulnerable version on their networks, although nothing was taken. However, 9 government agencies as of this morning admitted having the vulnerable version.
And I think the one thing we have heard, and there's been a lot published on this, and CISA, if you remember hearing that CISA organization, federal government has published a bunch on this. There's a lot of work to be done to dig deep to find out where malware may have gotten installed. So this is a little diagram that I've developed relative to remote patient monitoring. If you've got some sort of a device like a blood pressure cuff or a monitor that connects to the pacemaker to see how the pacemaker is doing, these are all things used at home. But they come from a manufacturer that, again, is using software and hardware that is supplied to them through a supply chain. And then you've got the people at home using it, whether that's some sort of an aid or the patient themselves, connecting maybe through their own Wi-Fi network at home or a smartphone, or directly out to the internet via the phone lines or the internet. And then interestingly, we're often seeing a cloud platform in the middle where this data is aggregated, because clinicians have made it pretty clear they don't want to be flooded with lots and lots of data that doesn't show anything out of the ordinary. They only want to be alerted when something important changes that they have to respond to. And so these cloud platforms are enabling this and providing dashboards. And then you get to the healthcare delivery organization and the electronic medical record and their machines where clinicians can review this information. But each of these jumps along here is a place where an attacker might get in. So this is kind of what we wanted to place in your mind to try and think about some of this. And for future reference, there is a cybersecurity framework from the National Institute of Science and Technology, and some of their many recommendations actually focus on supply chain. And some key ones are that they recommend that hospitals or other users have contracts with their suppliers that require the suppliers to do a good job on security. And then those suppliers have to be routinely checked to make sure they're complying with the contract. And of course, if there is a problem, there has to be a plan for recovery. So there is guidance, which too detailed to go into today, but I'll put this in the chat. This is from the Health Sector Security Council in how an organization should think about this as an end-to-end process for risk management. So with that, let me hand it back to Mitch and to Macy, see if we can get some discussion going.
Absolutely. So I'm taking a look here at the document template. And when we did some research for this, we thought of a few different areas. Number one that we thought of was big concern we have is, from my provider point of view, is long-term device component software support. And the reason why is a lot of these devices out there, they have operating systems that maybe get 7 to 10 years support, but they're designed for 15 to 20 year life cycles, which is a factor. And you also have to align with the NIST framework for this, the screening of these devices and making sure you have the appropriate controls and controls testing. To give you an example, for medical devices, the MDS2 form was recently updated last year. One of the main people behind that Yes, please, Macy. And one of the main people behind that was Michael McNeil, formerly of Philips, now of McKesson, who did a lot of work in designing this form. And for the most part, I've only seen 2 vendors so far give me MDS2 2019 forms. One of the companies happens to be Philips. That tells you everything you need to know. I'm still seeing 2013 forms for procurement phase. And making sure you have that long-term operating environment support, because it's going to be a combination of software and hardware and compensating controls, and also configuration change support. Let's just put it to you this way. What happens if AWS decides to up their prices by a factor of 10 and they have to switch cloud providers? How do you manage that change? And I came up with that one when I was looking at David's PowerPoint that he put together, and I thought, wait a second, that's an interesting point. So with that, anyone else here identified any challenges or risks? And Craig, I'm looking forward to hearing what you have to say, especially.
Certainly, you called out some of the key requirements there, and what my experience is that if there's no incentive for the manufacturers to build in some of those security controls, they don't. So certainly, first is setting the prescriptive guidance that will help them along the way. But that is, it starts all the way down to not just supply chain, but the components themselves, and building security from the start. So someone like Macy, probably has a very vested interest in that when the design from the ground up is built with security in mind. And just in agreement with a lot of the points being raised here in terms of it goes from each step in the process, there can be a weak link that can break the chain, if you will, in terms of because if you don't tackle some of these, especially at the hardware or at the manufacturer level, there is no easy fix often, other than could be replacing systems versus something that might be a software vulnerability can sometimes be patched. But if things are built into the chips or the hardware itself that make it inherently vulnerable, that is a more catastrophic type impact on the end user systems.
Absolutely, I couldn't agree with you more there, Greg. And does anyone have anything else they want to put down?
So I don't know where you would lump this, but the reason why I'm bringing it up is because it was in the news lately or recently, at least news that I've seen. So around open source, if you work with Python specifically, you usually you can get new libraries from a place like PyPy, and you go to PyPy and you import your library from there. But apparently there was some kind of vulnerability where if someone created a library that exactly matched a custom library that you were using, it would pull from the custom library, and it was a way to invade the user system, basically. Like you could inject your own code into there. So I don't know if that's covered in the diagram in one of those touch points.
It's implicit. I saw those same articles, and it's a good point. It has to do in DevOps how people are automating their pulling of these libraries. And there are some techniques apparently that if you're careful, you can avoid this vulnerability. But it's like so many things, I think, if I understood the article about this recently, it's like so many things, good hygiene is important. You got to wash your hands, and you got to make sure that the way that you are ingesting information into your system, that it's trusted information. which actually relates to the topic of the standards organization. It's trust and identity are the first two phrases in what we've been talking about.
Absolutely, and we've been tracking this as well. I actually had something very interesting come up with this. I did contract negotiations a few weeks ago for a med device security company, and one of the contract deliverables that I had to review was a manifest of open source packages, including Python packages that were used. So far, I have 1,300 vendors. They are the first and only vendor that has actually given me a manifest. Due to that event and SolarWinds, my company will now be requiring a manifest if you're using open source packages like that, especially ones from Python repositories. Because again, we realize that's a major deal. So
Certainly,
yes,
you know, open source disclosure, so that if there is a vulnerability that is discovered, that you can quickly identify all of the impacted systems. And so, yeah, that I'm just agreeing with you, Mitch, that that's something that's required, is that disclosure or manifest, if you will, of any open source. And as we move towards interoperability, there tends to be more, certainly a motion to leverage more open source material that has some implicit interoperability capabilities rather than trying to custom create your own modules.
absolutely.
And another phrase that we're hearing besides manifest is so-called software bill of materials. You may hear that phrase.
Right. And I would add to incentives. It's you know, it's not just for manufacturers to monitor each step, but it is, you know, building in secure practices. You know, in the case of, I think, SolarWinds, I think there was something missing in terms of the actual process, but it also goes to the options to implement more secure measures. Often it is now up to healthcare delivery organizations to force the issue by saying, we will only purchase from manufacturers that implement these ground set of principles in their products to ensure that, you know, a minimum level of security. I mean, I think that even speaks to the MDS2 2019 forms. What's the incentive for for manufacturers to update all of the MDS2? I think most of them, per FDA and other guidance, had created their first round of MDS2 forms, but to upgrade them, you know, sometimes it requires the organizations which purchase the equipment to say, without this information, that will influence our decision in terms of how we purchase. Because
I think
it's not a
you bring
mandate
up an interesting point about sort of the stage of evolution of cybersecurity for medical devices, because what you have from FDA are guidance documents, and they don't actually have force of law. They often appear as best practices, or they put the onus on the healthcare delivery organization to check to make sure that what they're buying meets the guidance.
That's exactly
and I
right.
think that's where we come back around to what Mitch was talking about with the MDS2 2019 and the general monitoring and risk management process for working with vendors. And we're going to have to kind of, in terms of incentives, it's going to have to be the buyer imposing requirements on the seller to say, if you want to sell to us, you've got to meet these requirements and maintain the patching and upgrading at a certain level. Otherwise, we can't do business with you. I think that's where the incentives are going to have to come, at least until the regulatory environment evolves to the point where they say, thou shalt do such and such.
And
Because
absolutely,
FDA is not a policing. I was going to add because FDA is not a policing organization, to your point, their guidance. And I think this speaks to where Florence has commonly said she would love to see the the TIPS label, just like when you purchase something like electrical equipment, you see the Universal Laboratories compliance or certified to say this thing meets the minimum certifications of security per these sets of standards. And sorry to cut you off, Mitch.
That's okay, Craig. And I think this is an excellent point. So what I'm thinking about here is I think this is a good chance for us to move into gaps. And I can start off the gaps by saying right now, building on what the FDA says is that you have number one, that it's more of a recommendation. However, the HIPAA security rule requires organizations to assess and address risks. So under federal law, while the FDA can makes recommendations, HIPAA puts us on the hook for having to assess and address risks to protected health information, which is exactly where we're at right now. The biggest gap we have is that, number one, most people don't know that we actually have to do this under federal law. So I would put that as the number one gap. People don't know what they have to do. And that under HIPAA, they're obligated. Or how to actually search for materials, because it is not very easy to find this material from manufacturers and vendors on security alerts for devices, and you end up cobbling together multiple sources. My favorites are ECRI, Emergency Care Research Institute, based out of beautiful Plymouth Meeting, Pennsylvania. You have a lot from CISSA, you have a lot from other sources, but ultimately the biggest source I have for software and hardware supply chain for medical devices happens to be ECRI, and I'm speaking as a technical reviewer for their security alerts. So that's what I have as really big truck-sized gaps there, and I want to hear what everyone else has to say. So let's go around and see what everyone else has to say.
Well, there's,
I'll just go ahead.
go ahead.
I was just going to say I concur. It's the prescriptive guidance of not knowing what to do, and certainly there are specific regulations like HIPAA that then, unfortunately, sometimes the delivery organizations may not know that they are in breach of until they have some type of assessor or an actual breach happens to find that they were lacking. And certainly there's the lack of prescriptive guidance that says, here's some guidelines, but obviously the goal would be, or the focus for most will be, well, what's mandated? What do I really have to do? And I don't want to put it in the terms of that organizations are deliberately not following best practice or guidance, but it falls back into priorities and trying to better assess where the risk lies, and having prescriptive guidance that says thou shalt have at least this done gets them at least focused on certain priorities.
And I think building on that, Craig, we can also talk about the need to actually have resources to do this, because again, this takes actual people doing actual work, and it becomes a very difficult task to get actual people to do actual risk assessments, actual contract negotiations. One of the big items I find, again, when I speak to many vendors, is that I'll often be told, you're the first customers that have asked for this.
That kind of reminds me of what I've been thinking about, that we've got between 5,000 and 6,000 hospitals in the United States. I think we saw a graph that said a lot of those hospitals don't have an intensive care unit. So that gives you some idea of the variability of sophistication, for lack of a better word. And part of that variability is, I've heard a number that 85% of these hospitals do not have a dedicated cybersecurity person, and many may not even have a dedicated IT person. They may have somebody who comes in from time to time. So when you're talking about the responsibility falling on the healthcare delivery organization to hold their manufacturers and vendors' feet to the fire to do the right thing, but they don't have the people, as Mitch says, to do this, I think eventually this may come back around to CISA, that federal organization, or possibly some other entity, to step in on behalf of the smaller healthcare delivery organizations, which could include physician practices, not just hospitals, that may not have the resources to do the many tasks involved in keeping a watch over this. That's a gap that I see, and Mitch said it one way, I'm saying it another. Same thing.
And the Nebraska Hospital Association, again, statistic from them: 75% of the hospitals in the state of Nebraska do not have a dedicated IT department. The one that got hit with ransomware was the one with the biggest IT department of any hospital state of Nebraska.
So it's no guarantee.
Very few organizations have someone even near the caliber of Mitch on their staff to beat you. So I can see where they would. It's scary to have vendors say you're the first to ask that, but it almost has an eerie correlation to Julian's presentation, talking about how surprising how many locations don't even have an ICU bed or the expertise or staff to actually monitor it if they did. And it's similar correlation here with the security analyst, someone to be able to be that cybersecurity expert for their organization. They lack, there's some of these, especially, rural and remotes, they do not have the capacity or expertise to do that. So how do we fill those gaps?
Yeah, at the risk of saying something political, we've seen with the vaccine rollout that having 50 different states and hundreds of different counties administering it has resulted in a wide variability in effectiveness. I think this lack of uniformity is a challenge. It would almost seem that if we look at the other developed countries that have more centralized or consistent healthcare systems, they have an opportunity to either monitor or enforce a little more consistently. I think that's a challenge, that's a gap that we have.
Absolutely. And I'm actually going to say something here. The one state I think that is actually taking it head on and doing it the right way is West Virginia, who's doing this out of state. They hired a major general out of their National Guard after he retired from the Guard to run their vaccine rollout. And the most vaccinated state by percentage-wise in the United States right now is West Virginia.
Good example.
This is something I never thought I'd say those words, but the approach that they've taken with the opioid crisis and with this, and I've actually spoken to Senator Joe Manchin's chief of staff. So you've got Democratic and Republican response there that has been focused on doing the right thing. And I look at them as a very bipartisan way of saying, this is how we get it to work. And the way to get it to work is you centralize. And we're trying to do a similar approach in Indiana. I've been doing a lot of work with Governor Holcomb with the Indiana Executive Council on cybersecurity, getting information out to people in a manner that says, okay, I don't care what party you are, you got to fix this. We're going to help you. And we're trying to do whatever we can because, again, we don't look at it as a problem for Indiana University Health. We don't look at it as a problem for Ascension or Franciscan Alliance or Community Health Network or Deaconess. we look at it as a problem for the little doctor in Evansville that refers his patients to IU Health. So we're taking that approach. And again, West Virginia is a model to follow.
Interestingly, we seem to have evolved into the mitigation strategies topic that's number 3 on our list.
Excellent transition. So we're down to our mitigation strategy. And so we've listed 3 items here for our mitigation strategy. And number 1 is the software bill of materials that we've talked about. So Alan Friedman from NTIA. So NTIA, for those of you that don't know, is the parent organization of NIST. They're the ones that have been championing SBOM, and NIST has been doing a lot of work in making the SBOM work. So this is truly a government-wide effort. And for those of you that don't know, NIST sets the standards that all the government agencies, including the DoD, have to follow. And one of the linkages that isn't really talked about too much is the linkage between the National Security Agency and NIST. Because who do you think tests all the cryptographic algorithms? It's our buddies in the NSA. So what my organization has done is we've aligned, as part of the mitigation strategy, NIST alignment with their standards for things like cryptography. So I put that as another mitigation strategy, would be alignment with established international standards. So.
But I also liked what you were saying earlier, maybe add a bullet about, I don't know how to capsulize what you said about West Virginia, but that the leadership that they took there, how would you phrase that?
Top-down goal-oriented leadership.
Yeah, and put in parentheses, as an antidote to fragmentation.
Yes. And that is the one state where I can claim Democrats or Republicans, they don't care, they get it done.
Cool. So, Runia, how are you finding this? Is this making sense? Do you have some questions? Oh, I don't know. You're on mute. Or she may have stepped away. And I see another name, Carlos, who may not have been on it initially. So welcome, Carlos. Just want to make sure that we give everybody a chance to talk here.
Absolutely. And Costas, are you here with us?
Okay, well, I'm not sure when we're expected to go back. I think we've still got another 10 minutes or so. Maybe we can brainstorm a little bit about, with all the brain power we have here on this breakout session, if it was, if we were king, what would we do? King or queen? What would we say would be the next thing to do? What are our recommendations or stipulations?
Absolutely. So I think the number one thing would be to develop a plan to develop a plan with reasonable goals to start addressing this problem with industry input. I mean, that's the biggest thing. You got to have goals.
And there are some documents from the Health Security Council, or a couple of documents. So maybe it's an implementation thing, is move from theory to implementation.
Absolutely. Again, I think HSCC does some incredible work, and I have the greatest respect for Greg and Eric Decker and everyone else. However, what everyone's doing there is they're talking about this, and everyone's doing this. Get all the organizations possible, or a large enough critical mass to agree to implement by a certain date. Well-established and reasonable goals.
That's true. Deadlines do seem to motivate both manufacturers and the recipients of those standards.
Absolutely.
I wonder how we can attack the legacy issue. You know, all these devices that are running, you know, Windows 7 and so forth. Typically, the challenge for the hospital is, but as Mitch said at the beginning, that these things have long lives. They have to be amortized. How do you get help to replace these things with more modern equipment? Where can that come from? Is that got to be a federal program? And you know, do we have to do sort of a what do they call it, cash for junkers kind of program?
If you draw a corollary from,
go ahead.
I was going to say, if you draw a corollary to things like PCI standards, which have specific, you know, had deadlines, had specific penalties by not complying, is you have this notion of compensated controls. It was the realization that you may not be able to do a, you know, throw out 10,000 patient monitors in a large healthcare organization and then replace them with another by a specific deadline, but allowed a grace period. Through compensated controls, you are still focusing on the security process, but allowing and incentivizing to move to get fully compliant. And that grace period doesn't necessarily last forever, but it's, if you are non-compliant by a specific deadline, that what are those guidelines for making sure that legacy devices are still secure, even if they don't have embedded security capabilities, can't be patched, can't be, don't have self-protections. How do you get those to be, continue to exist, but in a not indefinitely, but at least not, it's almost impossible to force a very heterogeneous environment, which is typical of healthcare, to force a complete revamp by a deadline. So I'm just calling that out as, but certainly options to provide incentive programs to upgrade to current, I think manufacturers and can help provide those incentives.
Here, Macy, I just put a sentence in the chat that maybe can help.
And I actually had another thought to that, Craig. We can't mandate that to buying something, but we can mitigate a common set of controls. And I'm thinking back to my DoD days with the system technical implementation guides, where you had a specific set of procedures you followed if you had legacy equipment or equipment you couldn't patch but was required for something, because you would have tons of equipment sitting there performing critical business functions that was running an unsupported operating system but was critical to, well, that environment, because the base didn't have 8 figures to put a new machine in. Base didn't have that budget. So I look at it, so mandating good common sets of controls that you can use, much like modeled after the STIGs, would be, I think, something that would go a much longer way, because getting a financial incentive program in that doesn't benefit public companies, not going to happen. But getting good compensating controls in, I think especially given that organizations now can get free donations of cybersecurity equipment under Stark Act because they waived that, I think that's an excellent benefit. because then you can put that in.
And I think the architecture that's being driven by, say, Netson and the cost incentives and benefits of being able to provide a more ubiquitous platform will help drive healthcare organizations to implement more state-of-the-art equipment because it enables them to do more. But yes, for the cases with these legacy pieces of equipment that may not be able to plug into this new interoperable ARC framework, or not so easily, is those, you know, to the point, compensating control or good mandates to say this is how these devices can continue to operate in your environment without being replaced.
Yeah, there's been just a lot of work on interoperability, and it's going on, you know, I think a decade now. It turns out that it is a gnarly problem.
Yeah.
And otherwise it would have been, I think, solved by now.
A lot
Hi,
of the gateway
Florence.
devices you see today are promoting that, right? It's how do I take a bunch of legacy equipment and then tie it into an interoperable, and now the focus shifts to that gateway. But
Yeah, it's sort of
Florence,
interoperability as a service. It seems to be emerging.
right?
Yes.
Yeah.
And I think also interoperability as a service has a chance of offloading a good chunk of the work we have to do to secure these systems. I know as a security person, hearing me say that might be anathema, but
That actually plays into your West Virginia example, though, is rather than us taking that on, being able to, as a service, be able to provide the processes and governance around that to make it more effective.
Yeah, Macy, you want to add that, interoperability as a service?
Yep.
Very good. Anything I can do to help you guys? Sorry, I've been going from room to room.
No, I see a big smile on your face. So I guess you're liking what we're writing here. So that's good.
It's great. And Macy knows I can't see anything, so she just made it bigger, which makes me even happier. We always have team meetings. I'm like, can you make that bigger? Yeah, I'm sorry. Oh, recording. I shouldn't be doing that. Telling my age.
Yeah.
So when
I
do we
wanted
do
to-
back? In a couple of minutes, do back?
Yeah, at 1 o'clock. So in about 9 minutes-ish. 6 minutes. Yeah, we're going to close it at 1.
Okay.
Well,
I-
you're already on-
I just-
yes, go ahead.
I just want to make sure we capture David's input about the Healthcare Security Coordinating Council. Now, David, if you want to make any other commentary and then how it addresses these particular concerns. You mentioned address insecure legacy equipment with incentives, compensating controls, and deadlines. So that's something we wanted to add to our list here.
Well, I will mention, if people go to the chat and scroll up a little earlier, I did put the file with the graphics in there, and those have the hyperlinks to the various sources from NIST and including the Healthcare Security Coordinating Council. And once you get to HSCC, they've got about 3 or more documents that are on this topic from the last couple of years that really pull together a lot of information on this. So I know we've got a student and a couple of people not directly involved in cybersecurity on the call. If you want to look at that, I think there'll be useful references for you.
Do you just want to put, as compared to the whole file, something that Macy can stick in the chat? Is there like a link or something?
Yeah, let me copy the links into the, let me go and grab them.
Great. And then whomever else was speaking, there were other things you wanted us to put under Healthcare Security Coordinating Council. Could you either put them in the chat or say them again slowly?
I think David was capturing the sentiments, but that some of that is already driven through the healthcare
Security Coordinating Council.
Coordinating Council. Is that correct, David?
I don't know. I'm copying the links over right now. Sorry.
Okay. You want to just copy them in, Macy? Thanks. Appreciate it. Oh, there's a bunch of them. This is great because we're going to be making the recordings available, but also we're going to be pulling all this together. And actually, Macy offered to write the report from all the 4 Google Docs. God bless you, Macy. But it's midterm week, so not for a while. In a couple of weeks, we'll be pulling all this together, and it'll be great to have the hot links in there. Thank you.
All right, there you go.
Wonderful, very thoughtful. Thank you very much. Teamwork.
Well, thanks for organizing us.
Florence. Thank you, Florence.
Always my pleasure. You know it. I always appreciate how much you all do.
Well, I'm going to sign off and take one of those little breaks. So excuse me.
And me as well. I'll be back in a few minutes.
Okay. Okay. Well, then I'm glad I'm here. So are there any other comments people want to share before we get to the wrap up? Because David and Mitch are going to have the opportunity, unless they anointed somebody while I wasn't watching, to present the report out back in the main tent. Is there anything else you all wanted to make sure we capture? Well, it sounds like it was a great discussion, looking at the notes. Good. And this will be great input to the standards work that we're doing and as it evolves as well. So we'll be going back to the main tent in I think like 2 minutes. Yeah, in 2 minutes. So if anyone wants to take a quick break, and you can just leave this open, and then you'll get sent back to the main tent automatically. Macy, is there anything else I can do to help you? No? Okay.
So Florence, thank you. Thank you so much again for the opportunity.
Thank you very much, Mitch, for stepping up as always. And it was your idea to have this breakout. So I think like a lot of people know about SolarWinds and the challenges in hardware and software and actually firmware, supply chain, put it all in there, right? But not many people know what to say about it. And I know that you do. So thank you very much for leading this discussion, because I think some people need to get more educated about it. So this is a wonderful opportunity. And then in our final report, it'll be included. So that's great.
Awesome. Thank you so much, Florence. And again, we're going to do whatever we can to keep educating people so we see some movement.
You know, I'll tell you, that's a theme across all the breakouts. I've been bopping from room to room. Sorry it took so long to get to you all, but I just started at the top. And a theme I've heard across all of them is education. Education for the patients, education for the providers, education for the manufacturers, education, awareness and education. And that's where it starts, right? So I'm really glad that you all have that in your plan too.
Awesome. Thank you very much, Florence. I know it's going to warp us back to the main room in a minute.
Yeah, actually in 8 seconds. So hold on tight.
Will do.
Okay, see you there. Thank you.
Okay, I think we have quite a few people here. Okay, so I hope you all enjoyed the breakout. It gave you some time to get into what I like to call very hands-on, very interactive. And now we're going to ask each of the groups. I don't know if you empowered your facilitator to be the one to report back, or you guys nominated someone in your group to share, but we're going to ask each of the groups to give about a 10-minute roundup of basically the 4 core points that we asked you guys to address. and basically share with everyone how it went and what you talked about, the recommendations, mitigation strategies, risks, wherever you focused on from their point of view. Just to share with everybody, you know, as Florence mentioned, we had our student facilitators in each of the rooms, and they took great notes, and our goal is to share, hopefully within the next week or two, the actual summary of all of the sessions. We're going to share with all of you and also other registrants who may be coming on board to view this on demand. So definitely you will all have access to both verbal and some written form of what went on in each of these breakouts. So with that, I would like to have the nominated individual to talk about what happened in security and interoperability and connected healthcare